observational international study of women over the age of 25 with acne. In fact, the mean age was 32. What I like about this study is that if you look up adult female acne, the definition differs. Sometimes they say 18, sometimes they say 20, sometimes 25. I would argue that an 18-year-old with acne is a whole lot more like a teenager with acne than she is like an adult woman with acne. So here, with a mean age of 32, I feel comfortable that we're talking about the group that I want to talk about. Additionally, this was not a telephone survey or an online survey. These patients were all actually seen by a dermatologist in addition to having questions asked to them about their acne. And what they found was a little surprising. So we just said adult female with acne is down here, right? It's the teal area on this picture. It turned out that that was actually fairly uncommon, that comedones were scattered all over the face, including down here, that this wasn't the most common acne that these patients presented with. In fact, their acne looked much like the acne of every other teenager who walked in the office, with the exception of it not being T-zone only. There was a lot of cheeks and a lot of nose and forehead as well. So what they found was that the lesion distribution in 90% of these patients was exactly the same as in the teenage population, that about 94% had comedones. It wasn't the absence of comedones, they were there. Only 11% had this teal stuff that we were talking about as being the quintessential adult female acne patient. And 18% had no acne in their mandibular area at all. So there's at least two types of adult female acne. There's clearly still this U-zone thing. Frankly, I think in my office it's more than 11%. I'd say about 30, maybe even 40% in my practice. But that's one subpopulation, and they probably require systemic medications, probably spironolactone, maybe oral contraceptives. But then there's a whole lot of women who have acne that looks like everybody else's acne that will probably respond quite nicely to topical therapy. We don't necessarily have to jump the gun to systemic. Allergan commissioned a study of these adult women with acne and asked them, when did your acne start? And fully 75% said it started when I was a teenager. So again, about 20 to 30% of people presenting for the first time as an adult. Then they were asked, what do you look like now compared to what you looked like when you were a teenager, when it first started out? And fully 75% said that their acne was as bad or worse now than it was when they were teenagers. So this is truly sort of a mini epidemic, at least coming into our offices. There's also a type of acne that's very poorly described in the literature. I call it last hurrah acne. It's the woman who walks in her late 40s, never had acne before, or maybe did when she was a teenager, and now it's back with a vengeance, and it's inflammatory, no comedones in this type for sure, all over her face. And when you check the androgens in these women, they're usually normal. But if you were to take a puddle of 50-year-old women with acne and compare it to a puddle of 50-year-old women without acne, the puddle of women with acne, the mean level of androgens is considerably higher, although still normal. So what the heck does this mean? One thing that it could mean is we never bother to check hormones in women until there's a problem, right? And there's a range for testosterone. So what if, for the sake of argument, I always lived at 5, and now I'm 30, which is normal, but it's 6 times where I used to live. Maybe that's what's going on. The other thing is, the other possibility is that as my estrogen sinks slowly down towards the horizon, that little bit of androgen that I make, at some point maybe is enough. And it's sort of like it tilts, right? You reach a tipping point where now I have acne, even though my androgens, again, look completely normal. Or is there end organ hypersensitivity in the follicles? A normal amount of circulating androgens creating havoc. We're just not sure, but I'm looking forward to hearing more about this kind of acne in the future. So what does acne mean to the adult female? Surely it means something different than it does to our teenagers. The adult woman is dealing with a whole different set of stressors, isn't she? She's dealing with maybe returning to the workplace, her sexuality, her motherhood, empty nesting, her midlife crisis, in my case, the midlife crisis of her husband, much more of an issue. Once present, though, clearly in an adult woman, this lasts for an incredibly long time, not usually disappearing until menopause. So what are we telling to this 25-year-old? Don't worry, I can get you under control. And then you just continue to use the medication for 25 years and it will all go away, right? So it's a very daunting task to these women. And not surprisingly, studies have shown that acne impacts on their quality of life more than it does their teenage counterparts. Additionally, when they utilize isotretinoin or treat their acne successfully some other way, even though they no longer have acne, they carry their psychological scars with them forever. Allergan commissioned a study asking adult females, what do you want? What do you want when you come to see your dermatologist? And they said they wanted a better understanding of their condition. They wanted to know why they have acne. Well, unfortunately, I can't tell them that answer, but that's what they want to know. They want education, and they want to be a part of their treatment plan. They want to be involved in their treatment plan. What don't they want? Well, they don't want what everybody else doesn't want. They don't like that we see them too quickly. But I think the interesting thing from this survey that I really took home was the concept that dermatologists did not look at my skin meticulously. Well, they're right, I didn't. I can diagnose acne from the door, and all other things being equal, in about 5 seconds, I know how I would treat this woman if she lets me. So no, I'm guilty. I don't look at the skin meticulously, but now I do, based on this. And I take out my magnifying glass and I turn my light on and I sit there, I count to 10, and I think about what I'm gonna make for dinner and what I have to shop for, because I don't need to do this medically, but wow, your patient satisfaction through the roof for 10 extra seconds of effort. So I strongly recommend this. So what's new in hormonal therapy? Obviously something that we utilize only in women. Men do not enjoy having hormonal therapy thrust upon them. So what's more effective? We've got a patient who's on multiple topicals, she's not getting better, we're going to orals. Are we going oral contraceptives or are we going oral antibiotics? Well, in a review of 32 randomized controlled trials, it was suggested that at 3 months, antibiotics are the winner, but at 6 months, oral contraceptives equal antibiotics. And of course, those patients were not put through the ecological mischief of being on an antibiotic for all that time. Perhaps starting both of them at the same time, which is what I do, and discontinuing the antibiotic as soon as possible, because oral contraceptives do take 3 to 6 months to really get up to speed. What's the best oral contraceptive for the treatment of acne? Well, I'll give you the punchline here. This study, which was a Cochrane review of 31 randomized controlled trials, said that there's no particular standout oral contraceptive. The older ones that had progestins that were androgenic were still, the estrogen component outweighed the progestin component, and they were generally, the net was an anti-androgen activity. The newer third and fourth generation, much better, with things like drospirenone and cyproterone acetate, not available here in the US, which are actively anti-androgenic. But nevertheless, the study was unable to show that they were superior to the older agents. There's also been a lot in, mostly in the lay press, about the dangers of drospirenone-containing oral contraceptives. It was suggested that they caused more problems with clots than did other forms of oral contraceptives. Well, in a Cochrane review of 26 studies, that didn't turn out to be the case. And in a prospective study of 85,000 women, there was again no significant difference between those that contained drospirenone and other progestins. The relative risk of oral contraceptives causing blood clots is about 100 per 100,000, with a normal of 10 to 50, and in the pregnant patients, and especially in postpartum, very much increased. So although medically there's no concern with using progestin, drospirenone-containing oral contraceptives, medical legally you might want to be avoiding the postpartum period, since that's the period of time where the incidence of blood clots does increase naturally. Spironolactone, growing in popularity in the last 5 years like I can't believe. I've been using it for years and all of a sudden it's the hot topic. We use doses about 50 to 200 milligrams a day in women who just have acne, but especially in women with therapy-resistant acne, especially if they also have hirsutism and alopecia, particularly helpful. Again, it takes about 3 months for it to get up to speed to do its thing, so you have to be a little patient. Most common side effects, breast tenderness and menstrual irregularities. Hyperkalemia was also on the list, but we'll see in a moment it's being taken off the list. There's also a black box warning that patients worry about and that we worry about, but if you read the fine print of the black box warning and look at where it came from, it was actually benign liver tumors in male rats. So if you're treating male rats, this is not the drug for you. Otherwise, there doesn't appear to be any data suggesting that it's dangerous in our female patients with acne. If you care, it's important to remember that it's not FDA approved for the treatment of acne. So what about that potassium? Well, it turns out in this particular retrospective database review that we don't have to worry about potassium in our patients who are between 18 and 45 on 50 to 100 milligrams of spironolactone a day for acne. In this group, 1,802 blood tests, only 13 showed a potassium above 5. Upon retesting, 6 of them, only 6 were still abnormal, and nobody came off the medication, nobody had any problems. So this gives you an incidence of about 7.2%, which is actually lower than the baseline population. So I no longer check potassiums. So I'd like to take my last couple of moments to talk about something that is also unique to adult females with acne, which is treating this disease when the patients are pregnant or lactating. As we know, our knowledge of drug safety in both of these conditions is extremely limited, as our patients have largely been orphaned from advances in drug therapy. There's a pervasive litigious atmosphere that surrounds the whole area of life that leads us all to sort of default to don't use anything ever under any circumstances, just to be on the safe side and to cover our butts and not really thinking about what's in the best interest of the patient. But being on the safe side is not always safe, is it? There are drugs that are important for these women to take, and when we tell them blanketly, no drugs, they think that means they're important drugs as well, and they're less likely to be willing to use their important drugs, including things like antidepressants in the postpartum period, where women may off themselves and may actually off their children as well. This is not a small risk, right? And we can't